Go to first slide, Naveen. You are able to hear us? Naveen, are you able to hear us, Naveen? We are unable to hear you, Naveen. Please log out, use some other system and come.
I think Dr. Pooja has joined, sir.
Yes, sir. Yes, sir. We'll have Pooja first. Naveen, you take some time. You have to rectify your system. So, Dr. Pooja?
Yes, sir.
Are you ready with your PowerPoint?
Yes, sir.
Okay. You can try sharing now.
Yes, sir. Sir, I'm logged in from my mobile and I cannot share my.
Okay, you please try sharing now.
Open
Yes,
your
sir.
PPT. Open your PPT.
Yes. Yes, sir.
Have you shared your screen from Zoom? Just open Zoom and share your screen.
Yes, sir.
There will be a green arrow at the bottom. Share screen. Share.
Yes, sir. Sir, I'm trying.
Open Zoom again.
Yes, sir. I'm sharing my.
Shared. How? Already shared, I suppose.
Yes, sir. I'm sharing my screen.
No.
Yes, sir. I'm sharing my screen right now.
Okay. Okay. Now open PPT.
Yes, sir.
Make it to slideshow mode, ma.
Sir, is it visible?
Good luck
Yes,
to you.
yes.
Yeah. Sorry, faculty.
Okay,
Sorry for the inconvenience. Please go ahead. Pooja, you have to switch on your video. I think you are connected with phone. If phone call comes, you will be in trouble. I request you to have somebody as standby.
Yes, sir.
Switch on your video if possible.
Yes, sir. I'm trying.
In your Zoom application, along with sharing screen.
Sir, I'll join from my laptop if it's convenient.
If it is open, join there.
Yes, sir. Okay, sir.
Faculty, very sorry. And students who are on YouTube and others, we apologize for the technical delay. I think with Zoom being used last 3-4 years, still people find challenging for various reasons.
I think this Pooja has already presented once, so
yes, sir. I thought that's why I didn't trouble them at all. She sometime back.
Yes, I understand.
Good evening, sir.
Yes. Share screen.
Please share your PPT, Kana.
Yes, sir.
I think you are fine now. Please introduce your unit chief, head of the department, and start your presentation. Faculty, please take over.
Sir, I'll open my PPT.
Yeah, please open.
நான் பாக்குறேன். வருது வருது.
इनको वो बहुत कम देती थी नोट कम था कोई बात नहीं
Go to your first slide, Kana.
Yes, sir.
You leave it like this and start your presentation. Don't let
Yes,
us
sir.
not waste time here on. Very sorry for faculty and for all the participants.
Sir, I'm extremely sorry for the technical glitch.
Yes, please
sir,
go ahead.
Yes, sir. Sir, myself, Dr. Pooja Jain, second year PG resident from Narendra Modi Medical College, LG Hospital, Ahmedabad. Sir, my PG teacher is Dr. Ritesh Andharia, sir. My case presentation is on peripheral arterial disease. Sir, I'm presenting a case of 70-year-old male patient residing in Amreli, Gujarat, from lower socioeconomic status, who came to LG Hospital with chief complaint of left thigh and calf pain for about 4 years, blackening and pain on tips of third and fourth toe of left lower limb since 15 days. Sir, patient was asymptomatic 4 years back, after which he developed cramp-like pain in left thigh, insidious in onset, gradually progressive, which increases on walking and decreases on resting. He started having similar pain in left calf for about last 3 years. Initially, patient had pain during walking a distance of 500 meters, which was relieved temporarily on taking rest, and now complains of pain at a distance of approximately 100 meters, which gets relieved on resting. Before 15 days, patient noticed blackening of tip of left third and fourth toe associated with pain, which was not associated with trauma or any discharge. It is continuous aching, gets aggravated on elevation of limb and relieved in dependent position of the limb. No history of any trauma, no history of postprandial abdominal pain, no history of blackouts, no history of syncope, no history of blurring of vision or chest pain and palpitations, no history of discoloration of fingers on exposure to cold, no history of numbness present. In comorbidities and past history, no history suggestive of diabetes, hypertension, epilepsy, TB, asthma, coronary artery disease, and transient ischemic attack. No history of any previous surgeries. In personal history, patient takes mixed diet, bladder and bowel habits are normal. Patient is smoker for 20 years, 20 cigarettes per day. Smoking index 400. No other addiction present. In family history, no similar illness in family members. Sir, in summary of the history, a 60-year-old male patient with history of smoking and no known comorbidities presented with complaints of intermittent claudication in left thigh and calf for 4 years and blackening and pain over toes since 15 days. According to the history, my provisional diagnosis would be peripheral arterial disease, most probably due to atherosclerosis. Sir, in general examination.
Pooja, please wait. Faculties, please take over the history and summary. Dr. Akash Bhai. Khanna sir, Rajgopal sir.
Yeah, Dr. Pooja.
Yes, sir.
Is it possible to move one slide before? Yeah, you are written as 70 here, correct?
Yes, sir.
And I don't want you to switch over to the last summary slide. I think, if I'm not wrong, 60.
Sorry, sir. Typing mistake. Sorry, sir.
Don't have to worry, but I just want you to remember these are small things. But then if it were to be something like 50 and 40, it would have made some difference. You understand?
Yes, sir.
Why it is important? Suppose if it is 50 and 40, let us say you have done the mistake. At this time,
according to the age, sir, The importance of age being, so that like atherosclerosis is common in old age, which is above 60 years. If there is thromboangiitis obliterans, it is most in third and fourth decade. And if there is Raynaud's disease, it is young females. So the importance of age is in probability of etiology of the disease.
Don't worry, don't worry. When we are talking about the leg, we don't want you to go on to Raynaud's disease and jump. Okay.
Yes,
So
sir.
since you mentioned about Raynaud's disease in young, then I have to ask you a question. If a young patient develops a leg ischemia, what do you suspect? Leg, not upper limb. Raynaud's disease affects which part of the body usually?
Sir, upper limb,
So
major.
now tell me, young patients come with the lower limb problem, ischemic. What do you suspect? Obviously, you don't suspect atherosclerosis. Okay,
No,
I'll
sir.
put also, she is a young female. She is a young female, say 20, 25, bilateral, some color changes, some pain. What do you suspect? Yes, yes. Think. Now you have to think out of the box. Don't narrow down only to the TAO and atherosclerosis, which postgraduates level examiners would like to ask you those questions.
Sir,
Otherwise,
vasculitis.
very good. So what
Uh,
are the causes for vasculitis? Well, what are the important causes? Yes, please go ahead. Yes,
Sir, autoimmune diseases like SLE.
very good. So you have to don't bring SLE, just say autoimmune. So these are
Autoimmune.
vasculitis syndromes. They are the broader category. There are many
Yes.
in that. So for the time being, we will move away from there. Suppose if a patient of this age and younger patients, can you think of anything else other than vasculitis? Other than vasculitis. Okay, neither it's a TAO. Now patient is say non-smoker only. I'll give the clue. Again, anything else you suspect the cardiac events?
Sir, if patient has cardiac event like atrial fibrillation, patient can have emboli.
So I know that rheumatic heart diseases are comparatively less common, but remember, nevertheless, you cannot completely rule out. So this is how you will start your questioning. So now come back to your patient who said that just to the first slide. Anyone else want to take over, please, externals? But since I've been asked, I'm just trying to.
Dr. Rachna Madam,
Yes.
Pradeep sir, or Akash sir.
Yes, sir.
Dr. Kanakvel sir is busy, so I may take over to introduce anyone.
No problem, sir. I think, please, anyone.
Dr. Rachna Madam, are you there?
Okay. So we'll start now.
Continue. Yes, sir.
Yeah,
Hello?
yes, madam.
Hello?
Please,
Yes, madam.
I would like to know more about the history of the pain. Pooja, can you elaborate on the pain which is felt in the lower limb? Can you elaborate?
Sir, ma'am, patient has cramp-like pain, which increases on exertion like walking for a certain distance, and then patient has to take rest for some time, after which pain gets relieved and patient can again do some physical activity.
What do you mean by claudication distance, madam? How do you measure it? Because that is very important, right?
Yes, ma'am. Ma'am, patient himself
I mean by saying that the patient, it decreases on resting, it means it must be a part of claudication, right?
Yes, ma'am.
Yeah, intermittent claudication. So how will you describe what is the claudication distance in this case? Because now you've taken the history properly, right?
Yes, ma'am. Ma'am, at present, the patient's claudication distance is 100 meters, after which patient has to rest for some time and then start walking again. Initially, it was 500 meters, after which patient had to rest.
So this claudication distance is decreasing now?
Yes, ma'am.
Okay, that's what I wanted to know. What is the nature of the pain? What type of pain does the patient complain of?
Cramp-like pain, ma'am.
The cramp-like pain.
It is sharp cramp-like pain patient has.
Okay.
How do you define claudication pain?
Sir, to define claudication pain, criteria, the patient has to have, while starting the activity, patient has no pain. After exercising muscle for a certain distance, then patient will start the pain and the pain gets relieved on resting.
So it's a reproducible cramp-like pain seen, which is increased on aggravation,
Yes, sir.
decreases on rest.
Rest.
Okay. It's a reproducible pain. What is the difference between pain in venous, arterial, and neurological claudication?
Sorry, sir.
Venous claudication and neurological claudication. How do you describe the pain? Yeah, venous
Sir,
claudication is a bursting type of pain which you seen at the end of the day, relieved by elevating lips. Neurological claudication is shooting type of pain, which
yes,
is seen on putting the patient on the first step. Okay, now from the
Yes, sir.
distance it's decreasing, you come to know that the disease is progressing.
Yes, sir.
Yeah, you said thigh, so you can go in a systematic way. Now, from thigh, the pain, the leg has 3 pumps: foot pump, calf pump on the thigh. So the
Yes, sir.
patient develop pain in the thigh.
Yes, sir.
So where do you expect the level of the disease to be?
Sir, either at femoral level or iliac femoral level.
So next
Uh,
ask for the gluteal claudication.
Yes, sir.
Do you
For
know any
gluteal,
syndrome,
yes,
do
sir.
you know any syndrome associated with gluteal claudication?
Sir, Leriche syndrome.
Yeah, what is Leriche syndrome? What is the triangle of Leriche syndrome?
Sir, in Leriche syndrome, there is blockage at bifurcation of aorta. And sir, patient has impotence.
Yeah, trial is gluteal claudication,
Gluteal claudication,
absence of
impotence.
femoral pulses,
Yes, sir.
and history of impotence. So when there is no gluteal claudication, you go upwards next. You said postprandial pain. What did you have in mind when you thought of postprandial pain?
Sir, mesenteric ischemia. If patient has blockage in
Yeah.
any of the mesenteric arteries.
Next is you ask for the loin pain. Is there any renal artery obstruction? Okay. Then go systematically up. So you went up to the blackout, syncope, blurring of vision.
Yes, sir.
So one small question, sir, at this
Yes,
stage.
please, sir. Since you said someone take over,
No. 15 days back, when he noticed blackening, one I want to know is it sudden happening or what we call as a gradual, without his knowledge, slowly color changing into black. Why is that?
Sir, it was slowly color changing into black because it is a chronic process and patient noticed it 15 days back. The process would be gradual, slowly happening.
I just told on. Yes. Now, if it is slowly happening, what do you think the cause for that? Why it has not become massive?
Sir, because there might be collaterals which have been developed if there is a blockage somewhere, and because of which the circulation has not yet reached the critical.
Now, this patient, if he develops the sudden onset, what do you suspect? This patient, he is 60 or 70, as you have written. If
sir, some cardiac event which might have led to the emboli formation and blockage of.
You would have told, chest pain or whatever, chest pain, MI, myocardial infarction, but anything else more common. Your diagnosis atherosclerosis. So I given a clue. He has got obviously atheromatous. So what is the cause for that? I want one word because these are very favorite words. It's called as atheroemboli. That word I want. Okay.
Yes.
Atheroemboli. That means atheroma, a plaque, which has gone distally suddenly. That would have even up. It goes carotids. What do you get? Carotid inside. That's what you have written there. Blackout, syncope. Why blackout?
Yes, sir.
Why blackout? Pooja, you are there?
Yes, sir. Yes, sir. I'm here.
So why
yes, sir.
blackout?
I'm here. Yes, sir. Blackout.
Yes.
Because of transient ischemic attack, if at all patient has
correct. Yes, go ahead. Blackout, blurring of vision, of course, BISION, no problem. Syncope, all this due to all this ischemic, emboli, small
yes, sir.
particles.
Yes, sir.
So that is what you get all these things, right? In the order, whatever it is, you are written there. Postprandial pain, blackout, syncope, all that thing you have written, that is fine. Suddenly you brought out noise to a discoloration of fingers on exposure to the cold. That's fine. What do you suspect if this patient gets this problem? Exposure to cold probably is not required, but suddenly gets discoloration of fingers. What do you suspect? Yes, will be called emergency. Yes.
Yes, sir.
For what? You said he has got a collaterals in the feet, correct?
Yes, sir.
But he develops no finger color changes suddenly.
Yes, sir. The
Yes. The same etheroemboli, one may be sitting in the brachial artery or little distally. It requires an urgent embolectomy. They are
embolization.
atherosclerosis for whatever reason. Good collaterals in the upper limb rarely affects the upper limb. Okay. You understand? It rarely
Yes,
affects
sir.
the upper limb. It affects the lower limb. But if upper limb is affected, it may be emboli. Is what you should try to understand that. Sudden occurrence can happen. Sir, please, somebody can take over.
If it's sudden embolism, what will be the type of pain? You have some 5 Ps or 6 Ps, 7 Ps are there. Do you know that?
Yes, sir. The patient will have a sharp shooting pain, paresthesia, pulselessness, pallor, loss of function, and sir,
Poikilothermia.
poikilothermia, coldness of the limb, and sir, pulselessness. 5 Ps, sir.
The pain will be pistol in onset, like pistol shooting. You can add another P. Another P is the limb will be perishingly cold.
Yes.
You can add this P to your. No, proceed first. Can we go to the next slide, sir? Well, madam, you want to ask anything, Rachana, madam?
Yes, sir. I would like to ask why she asked for a history of numbness.
Why do you ask for history of numbness? Puja, madam is
And
asking.
where exactly the numbness?
Ma'am, I asked about numbness at the blackening part of third and fourth toe. If patient has numbness or hyperesthesia or any
So it's only the third and fourth toe, no other place where the patient can have pre-gangrene symptoms or neurological problems.
Ma'am, over whole, sir,
You have mentioned no history of numbness, and that's why I'm asking which place exactly you wanted to know about the numbness. Okay, go ahead.
Dr. Shinoy asked you about the pain in the limb, apart from atherosclerosis and vasculitis and all those. You know what is popliteal entrapment syndrome? Have you heard about that? Popliteal entrapment syndrome.
No, sir.
Okay, popliteal entrapment syndrome is a syndrome where the patient gets the pain because of the pressure of the popliteal artery by the medial gastrocnemius muscle. Okay. And typically this pain occurs while walking, but if he runs, he doesn't get the pain. Okay. It is because of flexion at the knee joint, which is there. So while you are running, there is not the complete flexion is there. There is a partial flexion of the knee is there. But while you are walking, there is a complete flexion is there. So you get the pain not on walking, not on running, but on walking. So that is another which is there.
Okay, sir.
Your patient has got what type of ischemia? How do you label that? Is it acute ischemia? Is it a chronic ischemia? Is it acute on chronic ischemia? Is it a critical limb ischemia? There are the 4 types of ischemia which are there. So where does your patient fit?
Chronic
you know the difference between all these 4?
Yes, sir.
What is acute ischemia?
Sir, in acute ischemia, patient will have symptoms of gangrene, and sir, ankle brachial pressure index would be less than sir.
First symptoms first.
In acute ischemia, patient will
Acute
have
ischemia occurs because of what?
symptoms of
Acute ischemia usually occurs because of
erythroemboli, like sir said, if there is sudden occlusion.
embolism. Now, if the
Yes, sir.
embolism is there, you will get the, so all those 7 P's which are there, it will be there in that.
Yes, sir.
Okay, all right. And what is the critical limb ischemia? What do you understand by that?
So critical limb ischemia means patient will have symptoms of ischemia for 2 weeks, and sir, patient will have normal systolic ankle pressure of less than 50 mmHg with ABPI of less than 0.3.
Okay.
And for the patient will have symptoms for 2 weeks, less than 2 weeks.
So out of these 4, where is your patient fitting?
Sir, on acute on chronic ischemia.
Why acute, you are saying? The patient has got a pain for symptoms for last 4 years, isn't it?
Yes, sir.
And blackening of the tooth from how many
15
days?
15 days, sir.
Okay.
Patient has noticed it from
So
15
you can
days.
say that it is your patient is fitting over the acute on chronic limb ischemia.
Yes, sir.
Now, what are the various risk factors you have looked in your patient of the peripheral arterial disease? On history, what are the things you have looked into?
Sir, firstly, the age.
Yes.
Sir, secondly, patient's personal habits,
Yes.
like addiction history, if patient is a smoker or a non-smoker.
Right.
Sir, apart from that, sir, this particular patient, sir, doesn't work. But sir, if patient is working, then sir, occupation history. If he works, where sir there is vibration of fingers or in a machinery, so occupation history of the patient.
Yes.
And sir, then if sir patient has sir if patient is working or living in extreme temperature conditions.
Any metabolic problems? What are the various metabolic problems which can lead to?
Sir, altered cholesterol metabolism.
Yes. What else? What other metabolic conditions can lead to?
Sir, if patient has any systemic disease like hypertension or past history of any coronary artery disease or history of stroke or diabetes.
Yes. Can a thyroid lead to peripheral ischemia? Thyroid problem can lead to peripheral ischemia? Is that also can lead to the peripheral ischemia? No?
Yes,
if
sir.
somebody has a thyroid problem is there, it can lead to the peripheral ischemia also.
Yes, sir.
Now, tell what are the conditions where you get the Raynaud's phenomena? Or tell what is the difference between Raynaud's phenomena, Raynaud's disease, and Raynaud's syndrome? What are these three
Sir,
conditions?
Raynaud's phenomena is a clinical phenomena which entails 3 stages: stage of pallor, then sir stage of bluish discoloration, and stage of redness. Whereas sir, Raynaud's disease and Raynaud's syndrome. Raynaud's disease is a primary disease, and sir, Raynaud's syndrome is due to some secondary diseases in the body. Sir, in Raynaud's phenomena, in the stage of pallor, sir, initially limb is cold and pale, and it is due to vasospasm, arteriolar spasm, sir. Then, sir, stage of bluish discoloration, which is due to sir, accumulation of toxic metabolites, and sir, then stage of red pigmentation, which is due to when there is dilatation of arterioles, and sir, patient has pain during that stage. Sir, in Raynaud's disease, it is due to primary, it can be due to other primary reasons, like if patient has vasculitis or any other peripheral arterial diseases. And sir,
so can you name few arterial diseases which can lead to the, this is basically just to remember, you can say PCR. Okay. Pallor, cyanosis, redness. Okay, just to remember that, in that sequence which is there. So what are the various conditions which can lead to this phenomena?
Sir, first is Sir, any vascular?
All the vascular conditions can lead to this phenomena, whether it is the atherosclerosis or whether it is the Burgess disease, whether it is the vasculitis, whether it is a collagen disorder. So all these things, scleroderma, all these things can lead to the this type of reaction. But what is the Raynaud's disease? What are the characteristics of the Raynaud's disease?
Sir, there will be Raynaud's phenomena on exposure to cold and.
No. Who are the patients who get the Raynaud's disease? Male patient or female patient?
Female patient, sir.
Female patient.
Yes,
Age
sir.
of the patient?
Young female patient, sir.
Young female patient. Unilateral, bilateral?
Bilateral.
So, young female patient with a bilateral upper limb disease having this PCR phenomena is the typical Raynaud's disease.
Yes, sir.
Okay, I think you can go on the examination now.
In general examination, patient is examined after obtaining consent in a well-lit room after adequate exposure. Sir, attitude of the limb is sitting with limb flexed, moderately built and nourished, conscious, oriented, and afebrile. No pallor, cyanosis, clubbing, edema, or lymphadenopathy. Patient's BMI is 22.4. Vitally, sir, patient's pulse rate while palpating on right radial pulse 80 per minute, regular in rhythm, normal volume and character. No radial and radiofemoral delay on the right side. Sir, patient's blood pressure is 170 by 90 mmHg in right arm in sitting position. SpO2 99% on room air. So then inspection of both lower limbs. Sir, in left lower limb, blackening of skin over distal phalanx of left third and fourth toe in medial and plantar aspect extending up to the skin of proximal phalanx of the same toes. No visible discharge or surrounding skin redness or edema present. Other three toes are normal. Limb proximal to gangrenous area is pale up to mid-thigh. Skin, sir, on skin, loss of luster and dry skin, loss of hair over foot, calf and thigh, loss of subcutaneous fat, brittle nails in third, fourth and fifth toe, no discoloration along veins, no dilated tortuous veins, no obvious muscle wasting. Sir, in right lower limb, no obvious signs of ischemia. So this is a photo showing blackening over third and fourth toe, plantar and medial aspect. Sir, on palpation, on comparing both lower limbs, affected limb, which is left lower limb, is comparatively cold and temperature becomes normal at the level of the upper thigh. Dry gangrene of third and fourth toe, fourth left toe, absent sensations, no tenderness, no crepitus present, no tenderness along veins. Sir, capillary refill takes less than 3 seconds and sir, venous refilling time is approximately 10 seconds. Movement of all toes and ankle joints is normal. Sir, in right lower limb, no signs of ischemia. Sir, on examination, sir, sensation, touch, pain, temperature, and vibration sense present in right lower limb. No regional lymph nodes enlarged. Sir, on circumference measurement, sir, there is a difference of 2 centimeter in mid calf region and 1 centimeter in mid thigh region. Sir, ABPI could not be measured as sir, anterior and posterior tibial artery pulsation were absent. Sir, in peripheral arterial pulsations, sir, on left lower limb, dorsalis pedis, anterior tibial, posterior tibial, popliteal, and femoral is not palpable. Whereas, sir, on right lower limb, all these pulsations are palpable and bounding. Sir, on bilateral upper limb, radial, ulnar, brachial pulsations are palpable, and superficial temporal and common carotid artery pulsations are also palpable. Sir, in systemic examination, CVS, sir, not S1, S2 is normal, no murmur is heard. Sir, in RS, bilateral air entry equal. In per abdomen, sir, soft, non-tender, no organomegaly or no bruit heard. And sir, in CNS, GCS 15 by 15. Sir, after my examination, my provisional diagnosis would be a case of peripheral arterial occlusive disease affecting left lower limb, probably due to atherosclerosis with occlusion at iliac or femoral artery. Sir, for which further investigations need to be done.
Pooja, you are very, very fast actually in the sense palpation.
Hello. Hello.
Sorry, sir.
Pooja.
Yes, sir.
Why you say it is atherosclerosis?
Sir, given the age of the patient, and sir,
On
because it's a
clinical
chronic. Sorry, sir.
Why you say it is atherosclerosis only? No, why not Burgess disease?
Sir, given the age of the patient, and sir, because patient has pain over thigh region also, which means it will be mostly a large vessel disease. Sir, probably atherosclerosis, and also sir, patient on BP, sir, patient is
If it have been a
hypertensive.
large vessel disease, the only toes are gangrenous here. Yeah, I agree with you. Only the toes are gangrenous. Why the other limbs looks normal on your photograph at least?
Yes,
You
sir.
have not seen the patient.
Yes, sir.
Remaining that sole looks normal, the other toes looks normal. Only the third and fourth toe, I think, are gangrenous.
Yes, sir.
Yeah.
So due to
how you explain
microemboli in collaterals over those toes, sir.
Okay.
It may be because of that.
Yeah. No. I wanted to know why you were claiming it is an atherosclerotic disease. Only age is the one factor. What are the other factors you can say that it is atherosclerotic disease?
Sir, patient's BP. Sir, on recording patient's blood pressure, it was the patient was hypertensive. 170/90 was the BP of the patient,
According
and
to age, about his age, I think 60 or 70 years. You told 70 years
yes.
BP. That BP should be. I think other panelists also will agree. Why you say it is atherosclerotic? So sure.
Sir, it is probably due to atherosclerosis, and for which further investigations.
Have you told about the condition of the vessel wall?
But
No, sir.
he was very fast.
During your examination of the vessels, peripheral pulsations.
We want that's importantly.
Yeah,
There are
okay.
few things you went very fast.
What is it?
One is that brachial artery and all radial artery. Did you mention any thickening? That's what sir is trying to ask you.
Yes, sir. Yes, sir. Yes, sir.
Because
Yes,
Because
sir.
he's saying persistently that because clinically it is very difficult to tell whether it is due to that. We have to prove it on the investigations or other things. Before investigation, you can't say that it is a atherosclerotic disease only. You can
Yes,
say
sir.
it is probably a atherosclerotic disease
Yes, sir.
because history of smoking is also
Yes, sir. Patient's
there.
history
I
of smoking
think
is
quite
there.
heavy smoking is there.
Sorry, sir.
And clinically also the limb looks gangrene should be more extensive if it had been
Sir, patient has pregangrenous
involving the major
changes, which
arteries.
he
Because
noticed.
atherosclerosis, I think major arteries are involved.
Yes, sir.
Yeah.
Can,
Okay.
Dr. Pooja, just to develop, can you just go to the general physical examination slide to tell what are the stigmata of atherosclerosis you look for, so that it will help you to build up your answer at the end of the day.
Yes, sir. That's what I wanted from her, sir. Thank you, sir.
Yes, sir. Let us. They have to learn the basics and all, so that that's why I'm
Yes,
asking.
basic MBBS level. Yes, sir. Yes.
Yes. Whether it is a UG or PG exam, Dr. Pooja, these are the standard set of questions. Because what do you look in the general examination for any clue, which will give you atherosclerosis. So you
Yes,
are
sir.
written there everything, but in the pulse, radial pulse, both you have to mention. You have to mention radial wall thickening.
Yes, sir.
In the brachial artery, I don't know whether you have mentioned anywhere. Do you look for anything else? Especially brachial artery is more superficial. So thickened wall. What do you look? Inspection, sometimes you can make a diagnosis. Yes.
Yes, sir. Cord like thickening or thickened wall of the artery.
No, that is palpation. You want to look, you can tell, sometimes they are very, very motor. Motor means very active. Yes. What do you call it as? Yes. Yes. They are called as locomotor brachialis. Dancing brachialis. You can sometime next time when you go to the ward, atherosclerotic people, just lift the arm and see.
Yes, sir.
And this 170/90, sir asked you, what is the age of 70 plus? 170 is normal or abnormal or okay?
Sir, it is abnormal.
You think it's abnormal for 170. So usually we were told
diastolic 90 should be acceptable. Systolic beyond
Yes.
certain age, it is acceptable. It is not to be treated. No, though not normal, but not very significant also.
So what are the other evidences? Sometimes, okay, just to little bit progress further, xanthelasma, which is where rare. And anything else? So you have to look for atherosclerotic stigmata in the body as a whole, right? So there
Yes,
are some reddish spots you find next time you see. It is all given in Hutchinson and all. What are those called as? Don't tell me spider nevi. What is that? It is not spider nevi. The moment I say it, they will tell spider nevi. De Morgan spots. Next time you see. Yes. So what I'm trying to tell
Okay,
is
sir.
directly, this will help you. Then you start with now show the limb once. Show that, I just want to know, why did you tell it's a dry, just show this picture. So now tell me, where is this line of demarcation and where is this, is it diabetic patient?
No, sir. No
Not-
known comorbidities, and patient is not on any medications for the same.
Okay. Yes.
But-
Can you just show once the inspection slide, because you are so fast.
Sorry, sir.
Yeah. No, that's okay. That because especially here we have to follow, and sometimes
Yes, sir. Sir, in inspection.
if the limb is pale up to mid thigh, is it? Could you make out that? Really? Is
Sorry,
it
sir.
limb pale up to mid thigh? Could you make out that?
Sir, while comparing it with the opposite limb, sir, the pallor could be made out.
So always in a atherosclerotic disease, when you describe the limb, start from the most distal toe. That is correct. Then you go up, right? So you go up means you start from the below and slowly one by one. That ulcer description, ulcer where the black patch is there, near that ulcer is there. There is some discharge. Actually, I can see the discharge. That's okay. Then other toes you have mentioned. Then about the loss of hair you have mentioned there, then intermetatarsal spaces, then slowly go up. How do you know loss of subcutaneous fat? It's always a comparison.
Yes, sir.
You always compare. Like that you go on, and no discoloration along the veins. What does that mean? What do you mean by that? What is the statement? No discoloration along veins means, what do you understand by that?
Sir, if a patient has any associated venous condition as well, to rule out, like
No.
varicose veins.
Statement is not required. No discoloration along the veins. Okay, there's an agriculturist, they may have some prominent veins. That is not required. You want to tell that it is not venous ulcer. Not required in the toes. So that's how it is. Okay, sir, somebody can take us.
Dr. Pooja, I wanted to make a point that you should be able to mention about the gait of the patient, the attitude, the arches of the foot, and even you've started only with the positive findings right away in the lower limb. So we should be able to describe the panoramic view of the leg and the foot, and thereafter narrow down to the positive findings. And in the positive image also that you have shown, it is very clearly visible that there is scaling of the foot on the dorsum. And maybe you can even see a few callosities that go in favor of arterial pathology. So these, I think, we could have mentioned here.
Yes, ma'am.
Yeah.
Yes, ma'am.
Thank you.
Pooja, where did you feel for the dorsalis pedis?
Sir, just lateral to extensor hallucis longus tendon, in the proximal, on the dorsum of the foot, in the proximal half of the foot, not on the distal, sir.
Okay. So against which bone did you feel it?
Sir, against navicular and medial cuneiform bone.
And where do you feel for the posterior tibial?
Sir, posterior tibial artery is felt just anterior to medial malleolus against
Anterior to medial malleolus.
Sir, posterior, sorry, sir. Sir, posterior to
Where exactly?
Against calcaneum, sir.
Between what and what?
Sir, between medial malleolus and medial end of tendo-Achilles tendon.
And where do you feel for the femoral artery?
The femoral artery is felt at mid-inguinal point between ASIS, anterior superior iliac spine, and pubic symphysis against neck of the femur.
And popliteal artery?
Sir, popliteal artery is normally palpated when after making patient in prone position and flexing the limb and flexing the knee 90 degrees. Sir, it is palpated against tibial condyle on the lower aspect of knee joint.
Why did you see for the radio-radial and radio-femoral delay in patient?
So to see the occlusion.
So which condition can lead to radio-radial delay and which condition can lead to radio-femoral delay?
Sir, for radio-radial delay, there might be a cervical rib or thoracic outlet syndrome or in aberrant subclavian artery. And sir, in radiofemoral delay, sir, the patient can have atherosclerosis or obstruction at occlusion of artery.
What is the common condition that is called as for the radiofemoral delay?
I cannot remember, sir.
Coarctation of aorta.
Coarctation. Yes.
You know any systemic disease which can lead to this type of the presentation, that there is radio-radial delay is also there and radiofemoral also is there? Any condition?
Sir, arthritis.
Yes.
Arthritis, sir.
Which arthritis can lead to this type of a?
Not
Yes, Takayasu.
Takayasu's arthritis.
Okay. And sometimes also in the tubercular arthritis also you can have this type of the presentation because tuberculosis can be generalized disease. So what the Takayasu is the most important one which can cause that.
Yes, sir.
Now, your patient fits into, what is the Fontaine classification and Rutherford classification? What is that?
Sir, Fontaine classification is sir, for pain, claudication.
Where does your patient fit? No, it is not for claudication. No? Your patient has got a gangrene. There's the ulceration is there. So where this patient will fit into the Fontaines?
Sir, in mild.
What are the 4 stages of the Fontaines classification?
Sir, first stage is asymptomatic. Second is if patient has claudication. So, sir, in second it's 2A and 2B, mild and moderate, and sir 2C, severe claudication. Sir, then patient, sir, third is rest pain, and sir, in fourth patient has
what your patient has then? What does your patient has?
Sir, my patient has dry gangrene, which can fall into fourth.
It will fall in fourth, no?
Yes, sir. In fourth.
Ulceration or gangrene falls in the Fontaine fourth. No?
Yes, sir.
The patient is the Fontaine fourth, no? Okay. Now, you are right in saying that your patient is a case of atherosclerosis, no? Because all things they fit in your patient. That is age of the patient which is there, the patient has got the hypertension, he has got the proximal disease which is there, and the patient has got the acute and chronic limb ischemia is there. So all those things which are there, they are fitting into as the first diagnosis of atherosclerosis.
Yes, sir.
Okay. So tell what are the Chenoy's criteria for the Burgers?
So in Chenoy's criteria, right. Sir, I cannot remember, sir.
Young patient, smoker, involving even the upper limbs, distal vessel disease, Okay, so all those are the Noyes criteria. It is not the Chenoyes criteria, the Senoyes criteria which is there. Okay.
Yes, sir.
So how you are going to, because it's already 9 o'clock, we have to finish the case. So how you are going to work up your patient?
Sir, in workup of the patient, sir, first we'll do the routine blood investigations. Sir, in CBC and ulcer, seeing hemoglobin, WBC, platelet counts, TNR, LFT, RFT, serum electrolytes. We'll do, sir, the lipid profile of the patient. Sir, then to rule out other cardiac conditions which might be associated with atherosclerosis, we'll get 2D echo done. Sir, we'll get the Doppler done of this patient. Sir, I have done. Sir, patient's cholesterol is increased and LDL is also raised. Sir, in 2D echo, patient's ejection fraction, left ventricular ejection fraction was normal. Sir, left lower limb arterial Doppler was done, in which left external iliac artery shows a filling defect and absent flow, possibility of arterial occlusion. And sir, left low.
Just a small one interruption. Sorry. In left external iliac shows the filling defect means occlusion. So what would have picked up in a clinical examination in this patient? Simple question to you. Which I'm not sure whether you did in your auscultation. So that's the reason I asked you this question. You can easily pick up this. How? I don't want you to tell I will auscultate external iliac artery. That is the reason. So where do you auscultate? Yes. All the... Yes, please go ahead.
Sir, if any bruit is present,
Where?
Pelvic.
Remember, always pelvis, not pelvis. Always systolic bruits are conducted distally. There is a eddying currents passing through the external iliac, which is the artery, which is the thigh, which is very superficial. You can hear. Simple. Thin patient. Which is the artery? Femoral artery. So simple. You have to keep your stretch, and as usual, examiner will ask you which side you will use, bell or diaphragm or whatever it is. Please remember to do this, especially auscultating for mitral stenosis murmur, atherosclerotics. Yeah, what you are written.
Remember post-stenotic dilatation phenomenon. Post-stenotic, there is some dilatation on Doppler, and many times it is mentioned. You should have palpated abdominal aorta as well. Abdominal aorta as well. Try to be palpated.
Yeah, but since this should be done. And also remember, you should auscultate for the popliteal artery, because this is very important in a 70-year person. Aortic aneurysm.
Pooja,
Sir,
where do you palpate the aorta?
Yes, sir.
Where do you palpate the aorta?
Sir, along the anterior. Sir, along the anterior abdominal wall, sir, in supraumbilical, sir, against the vertebral column.
Which part of the abdomen you will palpate?
Yeah, I think. Sorry, I was disconnected. Sir is continuing. Yes, sir, please.
Below the umbilicus or above the umbilicus?
Hmm. 50-50. Come on. Yes.
Sir, below the umbilicus.
Why below the umbilicus? Why not above the umbilicus?
Sir, because of the branches that aorta gives, sir.
Aorta divides into what?
For common iliac.
So two common iliacs, and they arise at the level of the umbilicus and L3 level. Okay.
Yes,
and that is why you have to always palpate the aorta above the umbilicus, never below the umbilicus.
Yes, sir.
Now, in this patient, you are doing the CT angiography.
Yes, sir.
What type of the CT angio you are doing?
Multidimensional normal CT angiography.
Okay. Why you want to do a CT angio in this patient? The reason for that?
To sir know the occluded segment, so that sir further management can be done. Length of the occluded segment, and sir if there are any collaterals which have been developed, so they'll be delineated well. And sir if there is
What is that known as, which is seen in distal normal vessels beyond occlusion?
sir distal runoff.
So if you are asked one thing to see on the CT angio is the distal runoff. Why distal runoff you are interested?
Sir, to see if sir because sir it is compensated. The limb ischemia is not
If you want to do any active intervention, until unless the distal runoff is present, you cannot do that.
yes, sir.
Okay. Now, what are the various types of the angiography you can do?
Um,
You know what are the various types of the angiography?
I forgot the name.
When we did not have the CT and MRI and all those, which angiography we used to do?
Yes. I forgot the name of the angiography.
You know, the Seldinger's
Seldinger's technique. Seldinger's angiography.
transfemoral,
Yes, sir.
Okay.
Yes, sir.
So you can do a Seldinger's technique, you can do a CT angiography. Any other angiography you can do?
Sir, digital subtraction angiography.
Any other angiography?
Sir, MDCT, DSA, sir, and then
If the patient's
sir,
creatinine is high, what are your options?
sorry, sir.
Creatinine is high. Serum creatinine is high. What are the other options?
So then we can go for MRI of the limb or
You can do MR angiography.
yes, sir.
Any other angiography which can be done if there is? You want to avoid the nephrotoxicity. So can you inject something else apart from the contrast which you are injecting the CT angiography?
Non-ionic contrasts.
So you can use the non-ionic, yes, that is one. Yeah, majority of the time nowadays the non-ionic is used. No?
Yes, sir.
Right. So apart from those non-ionic contrast, anything else which can be? Any gas which can be used? You know any gas for carrying out the angiography?
No, sir.
CO2, no? You can use the carbon dioxide angiography.
Yes, sir.
Right. So you know what is the task classification on angiography? Any idea?
No, sir.
Have you heard the name of the task or not?
No, sir.
Transatlantic something.
I've heard the name, but I don't know the classification.
This classification is very important in the CT angio
Yes.
to decide about what type of the treatment you are going to offer to the patient. Okay, depends upon that how much is the stenosis is there, how much is the length of the obstruction is there, and
Yes,
what
sir.
is the distal runoff is there. And based on that, you can, because there are two basically treatment, if you have to go for any active intervention, either you can do open surgery or you can do endovascular surgery.
Yes,
So
sir.
it's all decided based on the task classification which is there. And task classification is different for the different places. Like aortofemoral will be, aortoiliac will be different, femoropopitial
Yes.
will be different, and infrapopliteal will be different, depending upon the location of the block which you are dealing with.
Okay, sir.
Okay, go ahead. What have you done for your patient?
Sir, CT angio was done, and sir, in CT angio, sir, common iliac artery, sir, on right side and left side, calcified atheromatous changes, however patent. Sir, in external iliac artery on right side, calcified atheromatous changes, however patent. And sir, on left side, complete absence of contrast filling is noted for a segment of 5.3 mm, just from its origin, suggestive of complete block, distally reformed, sir, patent. Sir, in common femoral artery, again calcified atheromatous changes, however patent. And sir, thereafter superficial femoral artery, popliteal artery, anterior tibial, posterior tibial, and common peroneal. And sir, sir, they are normal and patent. Sir, then this is the CT angio plates.
Yes.
And
Yeah, just show the CT angio. Okay. So distal runoff is good here, you know. So this
yes,
is
sir.
the good part in your patient here. Right. So there is obstruction on the left side, also there is narrowing on the right side is there, you know.
Yes, sir.
Right. Okay. So what is the plan now? Just show the CT angio.
For this one.
The charger.
Uh,
The charger comes together.
You have images, Dr. Pooja? I can't see that. You have.
Image.
okay, sir.
Please.
Yes.
Yes, sir.
Yeah. So my question to you, can you hear me? There's some disturbance.
Yes, sir.
There is a problem in the external iliac artery, correct?
Yes, sir.
Can you show with your cursor there? Yes. Read that. Read.
Can you see the cursor, sir?
Yes. Where is? Yeah. Yes. You can see some collateral, right?
Yes, sir.
That's what it is. You can see collateral
Yes, sir.
and the ACIS and even trochanteric.
Yes, sir.
Sir, is the problem from some sound or?
Yes, sir. From your side, sound is breaking. You can switch off the video. That might improve the audio quality, sir. Time being.
So,
when you ask.
Is it better now? No.
Yes, sir. It is better.
So you can see I can see the collateral around the anterocephalus spine as well as trochanteric anastomosis. You know, there are some anterior cruciate, posterior crucial.
Yes, sir.
So in spite of that, why the distal limb has got gangrene, the 2-3 tests?
Sir, there might be blockage of. There might have been the starting of blockage of micro. Sort of the.
So there is some sound problem is there everywhere. Okay, Pooja, what I wanted you to understand is there is one block is above, and also it can be multiple blocks. That is what was trying to tell you, the distal runoff. Okay.
Yes, sir. There might be blockage in the collaterals.
Okay, sir. I think there's some.
Rashna Madam, Khanna sir, you can take over.
So, Pooja.
Yes, ma'am.
Madam, you are muted. Please unmute.
How will you manage now this case? We have all the pictures of CT angiography. We have the patient profile. We know that he's not working, so his occupation is not a big issue at present. So how will you now proceed for the management?
Sir, ma'am, in this patient, we will go for percutaneous transluminal angioplasty and balloon dilatation of the stenotic segment. That is one of the treatment options, ma'am. Along with, ma'am, there is pharmacological and then surgical intervention. For high blood pressure, we can start uh, appropriate treatment, antihypertensives, and ma'am, for surgical.
So what will you do first? What will you do first?
Ma'am, first we will, ma'am, we'll try to improve the hypertension. We'll try to control the hypertension of the patient, and ma'am, if possible, smoking cessation, if that is a contributing factor for further progression of the disease, and then we will move on to surgical intervention.
What is the correlation of smoking with atherosclerosis?
Ma'am, it causes.
Does atherosclerosis and smoking have some correlation or not?
Ma'am, it causes thickening of the vessel wall.
So we can always encourage the patient to have that cessation of smoking for the betterment of not only that particular limb or the other vessels also. Okay.
Yes, ma'am.
The first
Yes.
is encouragement for cessation of smoking. Does any pharmaceutical agent now help for the vascularity in the lower limbs?
Ma'am, we can start antiplatelet medications or like clopidogrel or ecosprin.
How much?
75 mg clopidogrel OD and ecosprin either 75 or 150.
Are you going to give both or one?
One, ma'am, not both.
Which one? What are the indications of ecosprin? Low dose ecosprin, what will be the indications? What care will you take while you will be giving those ecosprin? Will you be monitoring the PT-INR of the patient?
Yes, ma'am.
That will be one of those factors. You will always look for hidden signs of blood loss, obvious and hidden signs of blood loss, of
Yes,
the
ma'am.
patient. Okay.
Yes.
So, okay, then you will go for the definitive management.
Yes, ma'am. Ma'am, in definitive management, there we can try the minimally invasive percutaneous transluminal angioplasty, or we can do bypass surgeries. We can do either aortofemoral bypass or femoral bypass in this patient.
What was the, have you seen for the infrarenal aorta? Were the kidneys spared in that angiography? Were we able to see it for the renal runoff in the angiography?
Yes, ma'am. Ma'am, renal artery was patent.
So it was only the infrarenal aorta involved, right?
Yes, ma'am.
So you're going to go for a aortofemoral.
Yes, ma'am.
Of the left side.
Yes, ma'am.
And then you had another option. What did you say?
Or either femoral bypass.
So what type of anastomosis, what type of bypass, what type of material?
Ma'am, either Dacron or ma'am PTFP graft can be used, polytetrafluoroethylene, or ma'am GSV, more physiological would be great saphenous vein can also be used.
What is the ideal criteria for a graft? Anywhere in the body? What are the ideal points which go for a good graft anywhere in the body? It should be non-allergic, Anna.
Yes, ma'am.
Anna, smooth. Okay. Yes, sir.
Yeah, one question to you. Can you hear me, Pooja?
Yes, yes, sir.
Have you heard of statins?
Yes, sir.
Do you want to give to these patients? And if
Yes,
so,
sir.
what is the purpose?
Sir, they are HMG co-reductase inhibitors. So, sir, to reduce the cholesterol and the underlying process of atherosclerosis and formation of more plaques in the body elsewhere in other vessels of the body.
Do you think it will happen like that? Is 70 and do you think is that obese to get all these things? What is his weight? Have you measured his weight?
Yes, sir.
Is it that
It was sir
obese?
66 kgs.
So, height, if you look at looks to me tall person, whatever it is. What I want you to understand is they are mainly given for to stabilize the plaque. So what is the meaning of their stabilization? Means?
So that's stabilizing the plaque means so that the plaque doesn't get friable and there are no atheromatous emboli and result in acute limb ischemia or acute conditions of.
Yes. Adding on to one more thing to you, you said sometimes femoral bypass. I don't think that is indicated here. So you have a short segment means you can have even one big bypass, another even balloon you can try for a. Today they go up to the even dorsalis pedis artery and posterior tibial and do that. But anyway, just one more thing I would like to mention. If you find also carotid bruit in your patient, you need to look into the carotid arteries also. Okay. And then the one or two question, what do you do with this gangrene? I think time is gangrene. The two is there, no? Somewhere.
Yes, sir.
You are going to remove now only? Or what is that? Today it has come to your OPD, so you'll get chance to remove and then refer to for a bypass. Or what is your strategy? Yes.
The patient is in pre-gangrenous phase of blackening of the toe, sir. So we can first do the bypass surgery if at all needed, and then we can do the definitive management.
No urgency to remove a dry gangrene. You understand? Yes. Patient has got a pre-gangrene. So do the unless there is an active infection.
Yes.
Understand? So there's no indication. So just cover the ulcer dressing. So there's a method from the treatment which you have to follow. Care of the ulcer, dressings, antibiotic, care of his pain. You understand? And
yes.
Then measures to prevent the further damage to the limb. Try to conserve. And ultimately at the end of the day, that black thing will go. That is a different thing. So that's called conservative amputations. Conservative. See, you are conserving as much as possible. Tissue loss has to be minimum. Of course, then you do the other thing. Sir, please, sir.
Pooja, do you know which additional procedure a cardiologist who is doing minimally invasive procedure will do along with or before doing angioplasty? Same procedure.
Sir, in this patient?
Yes. Or any patient who is taken for minimally invasive treatment for some block. They call it shoot. If you don't know, they will always do cardiac angiogram.
Yes, sir.
They will always check whether, because this is generalized disease, they will check whether cardiac vessels or arteries are patent or acceptable or not.
Okay, sir.
I think it is understood that when today's CT like this, it is covering. Sorry, you have to look at the aorta also. Yes.
Sir, I think it's already 9:25. We can close this case if no more questions are there. Kanagwal sir, are you there? Pooja, any queries from your side to faculties?
No, sir.
Khanna sir, Shinoy sir, Rachna madam,
That's
should we
it,
close this case?
He has done
So
well.
this
Sir.
is
He has
a
done
this
well.
is a very ideal case for what is called as the revascularization of the limb. So after you have done the systemic control for this patient in terms of the blood pressure and other things which are there, you can land in either in this patient the endovascular treatment or also the open treatment. Both are an option in this patient. So you can also go for the endovascular treatment and do not go for hurry for the amputation here. So
Yes.
always first revascularize the limb and then if required, you may have to go for the conservative end in this patient. Okay.
Yes, sir.
I agree. This is a classical case in which revascularization is needed. An inverted tree appearance, it can be seen, shows that revascularization is likely to have a good effect. And you must read about selective angiography as to how it is done. And that selective angiography can precede the endovascular procedure
Okay, ma'am.
to define what exactly has to be done.
Okay, ma'am. Yes, ma'am.
Yes, madam, definitely.
Good presentation, Pooja.
Thank you. Thank you, sir. Thank you, ma'am.
Pooja, you can unshare, and Dr. Naveen, you can share
Sir,
your
I think you can call Dr. Naveen.
Yeah, Kanagla sir is there.
Okay, sir.
Dr. Naveen, share your screen.
Naveen, are you with us?
Yes, sir.
Please switch on PT.
We can't hear you, Naveen. See,
Hello, sir.
yes, we can hear you. Slides.
Hitesh, sir, can I request Pooja to share the PowerPoint, sir? I'll send the PowerPoint of Naveen to her. Because still he has some issues which he could not resolve, I think, sir.
Yes, sir. I will share the
I am
presentation.
sharing you the PPT to you, ma. You can
Yes.
try doing it from your computer. Sorry for taking this help from you, but please help us out.
Yes, sir. Definitely.
I've sent you by WhatsApp, Pooja.
Okay, sir. Sir, it'll take 2 minutes. I will try.
Yes, it is a sort of a little bigger presentation.
Yes, sir.
You want me to send your email? You can send your email to me. I will send it across.
Okay, sir.
Have you got it in your WhatsApp, ma?
Yes, sir. I've gotten it on my WhatsApp.
You'll be able
Sir,
to
I'll try and
download
open it on my laptop.
Yes, please.
Yes, sir. Okay. Sir, I'll try and share it from my this thing.
1 second. I'll send you by email also, Dr. Pooja. I think you got it already.
Yes, sir.
Yes. Dr. Naveen,
Yes, sir. Shall I start?
you have to switch on your video from your side. Please start your presentation. Dr. Pooja will help you to move the slides. Pooja, you are in the right window. Good, good. You are in the right window.
Okay, sir.
Good luck to you, Dr. Naveen. You switch on your video.
Hello, sir.
Pooja, I request you to swap to the slides.
Naveen, go ahead. Naveen,
Yes, sir.
Naveen, can you see the slides? Pooja, we can't
No.
see the slide.
No, sir, I am not able to see the slides.
Sir, Kanagwal sir, let me share. I have downloaded. Let me share.
Yes, sir. Yes, sir. Yes, sir. Pooja, please unshare your screen. I'm not sure that many of you need to upgrade your WhatsApp to the most recent version.
So my screen is unshared.
Is it seen,
No
sir?
problem. No problem, Dr. Andariya sir. This is yours, sir, Professor Hitesh sir.
Yes, yes, yes.
Naveen, you start your presentation. I don't want much delays.
Good evening, sirs and professors. I am Dr. Naveen Rajan, final year postgraduate from Stanley Medical College. My unit professor is Dr. B. Sathipriya ma'am. I'm going to present a case of thyroid neck swelling. Ramani, a 40-year-old female, came with complaints of swelling in right side of neck for past 2 months. Questioning history. The patient was apparently normal 2 months back. Later which she noticed swelling in right side of neck, which was increasing slowly in size to attain present size. It is not associated with pain. No history of difficulty in swallowing. No history of difficulty in breathing. No history of symptoms suggestive of Horner syndrome. No history of hoarseness of voice. No symptoms of hypo or hypothyroidism. No history of cough with hemoptysis, breathlessness, jaundice, headache, bone pain or swelling. No history of any other swelling in neck or elsewhere in the body. No history of loss of weight. No history of loss of appetite. Past history. No history of any known comorbidities. No history of previous irradiation to neck. She has a history of cervical lymph node excision done during childhood. Personal history, she consumes mixed diet. She has normal bowel and bladder habits. She has normal sleep pattern. No history of consumption of Vascular family vegetables. Menstrual history, she attained menarche at 14 years of age. Regular cycle, moderate flow. Last menstrual period is 15 days back. Family history, she has no similar complaints in family, and she has no malignancy in family. Summary. Middle-aged woman with no risk factors, patient with complaints of painless swelling in right side of neck for 2 months, which is progressive to attain present size with no symptoms suggestive of hypo or hypothyroidism and malignancy.
Faculties, please take over. Rachna madam, Pradeep sir.
Yes, Dr. Naveen, you
Yes, ma'am.
started with the fact that patient noticed the swelling 2 months back and it increased to attain a present size. We don't know what was the size of the swelling 2 months back and what is the size of the swelling now. And we have no image also to correlate. So it will be a good idea to say patient noticed the swelling, say approximately itna by itna centimeter in size as gestured by the patient and has increased in size to the current size of itna by itna centimeter, right?
Okay.
So that may be one thing. Then you said the patient did not eat anything from Brassica family of vegetables. Can you name a few?
Broccoli, cabbage,
Yeah.
rape, soybeans.
Yeah. And so which malignancies did you look for in the family? You said that there is no history of malignancy in the family.
Medullary carcinoma, thyroid.
So you basically looked for head and neck malignancies.
Yes, ma'am.
Then you said right side of neck, upper part of neck, central part of neck, lower neck. Which part of neck? Are we assuming it to be thyroid because you're presenting a thyroid swelling? So because it could be a lymph node swelling also, no? It's a unilateral swelling. So right side, upper part of neck, lower part of neck.
But it's,
You could have
it's,
mentioned because can you name any other swelling which can happen in the say right lower neck other than thyroid?
lymph node swelling.
Yeah. So any respiratory complaints that you looked for?
From CS, no difficulty in breathing, no breathlessness complaint, no dysphagia complaint.
Yeah. So all I wanted to stress upon was that don't go with the predetermined idea that you're presenting a case of thyroid only. Yeah. The other examiners can take over.
Hello,
Hello, ma'am.
Naveen.
Sorry.
Yeah,
Yes, ma'am.
Naveen. You specifically asked for bone pain, right?
Yes, ma'am.
Which particular bone did you inquire into, or with what particular bones for bone pain?
Skull, ma'am. Skull.
Skull. And so skull and headache.
Vertebra, ma'am. Skull and vertebra.
It is vertebra first, yes. Why are you asking into bone pain so much? Why?
From metastasis, ma'am.
So one is vertebra, one is skull, okay. Then pelvis and ribs, right? What are the, if you think of metastasis, what type of metastasis are present in the, particularly in the skull, which you can feel also, of the thyroid? What type of metastasis are you suspecting, and what is the feel of the metastasis in the skull? The
Hello, ma'am.
swelling, yes?
This pulsatile swelling, ma'am.
Yeah, that is pulsatile. Let's talk something about, you mentioned Horner syndrome.
Okay.
What is Horner syndrome? What is Horner syndrome?
Just 4 components. It occurs due to the compression of the sympathetic trunk. The components of
compressed?
meiosis.
I didn't get you. What is
Sympathetic
compressed?
trunk, sympathetic.
Cervical sympathetic, cervical sympathetic, right?
Yes, ma'am.
So, what are the components?
Meiosis, anidosis, enophthalmos, and ptosis, ma'am.
Ptosis, meiosis, and facial. And is it ipsilateral?
Yes, ma'am.
What are the other things which can have this Horner syndrome? What other disease? More common in which other disease? What is Pancoast's tumor? It is more relevant there, okay?
Yes, ma'am. Upper lobe lung tumor.
Yeah, it is more common. Horner's is more common there, right?
Okay.
You were talking about family history. So, what family history? The patient could have hypothyroidism or hyper. Okay.
Yes,
So,
ma'am.
what is more common in a family history, hypo or hyper? Especially when the patient is having a thyroid swelling. What is Men's syndrome? Multiple.
Sorry, ma'am.
Men's syndrome. You said about menstrual history. You said something about menstrual history.
Yes, ma'am.
You didn't tell me about anything about her gravida and para. Is she married? She has any children?
She married, ma'am. She married. She has 2 children. She has done PS for 10 years back, ma'am.
Okay, that was, I think, missed in your history part. Okay.
Sorry.
Okay.
Yes,
thank you. Thank you.
Naveen?
Yes, sir.
At the end of this history, whatever you have taken, what is that you have in mind, roughly?
Probably she has benign thyroid swelling, sir.
that's what madam has told you. Only with this 2 months swelling on the right side. Suppose I tell you it is not malignancy. I'm just giving you stimulate your interest, not thyroid swelling. Okay. You have written there no hyperthyroid, no. What else you would have thought of? I'm just trying to ask you if it is a lymph nodal swelling for that region, what are the things you would like to consider? 2 months. I have given you the clue that it is a lymph nodal swelling. This is just for you to stimulate the interest. Just quickly, 2-3 possibilities.
Sorry, sir.
Say, don't think everything is thyroid swelling, correct?
Yes, sir. Yes, sir.
With no evidence. So if it is a lymph nodal swelling in a middle-aged woman, what you would have thought of in this area?
Yes.
And still thyroid swelling. My question to you is that. You understand my question?
Yes, sir.
Just think and answer this question. If it is a lymph node swelling, what will be the thyroid malignancy can present like this?
Papillary carcinoma, sir.
So this is how you should go ahead. Suppose if this patient were to be a quick the terracotta tumor and all those things, and you find a short duration, rapid growing swelling, if it is a lymph node, what you would have thought of? This is how the questions will come. Yes.
Anaplastic, sir.
No. You don't have to jump to anaplastic carcinoma. You would have thought of oral malignancy. You understand, no? Level 2, level 3. I can understand it as level 2, level 3. Oral malignancy. Okay. So, but those are the things. So, you are written here, no suggestive hyperthyroidism and malignancy. So why did you say it is not malignant now? History-wise?
There's no history of loss of weight, loss of appetite. There's no.
That is why I asked you this question: loss of weight, loss of appetite. You forget about it. Yes. Anything else?
There's no process symptoms, sir.
Yes, please. Yes.
No process symptoms.
Yes. See, what I wanted was not that pressure symptom hoarseness. Madam has been already clarified that you should have hoarseness in the voice. You should have put that changes, change in the voice, hoarseness. What is the difference between that? Suppose this patient has got difficulty in swallowing, you would suspect malignancy? Not necessarily.
No, sir. Yes.
Then hoarseness is important. Why hoarseness is important?
Sir,
yes.
The swelling would have compressed right.
You please don't use the compression. Big, however big, they rarely compress the recurrent laryngeal nerve. It is more of infiltration. So that's why you suspect. You understand, no?
Yes.
That is what we want you to understand. Either it is infiltration, number one, or other lymph nodal swelling, or skull metastasis, all that you are told. Right?
Okay.
That has been clarified. Yes, that's all, madam, from my side.
One more thing that I wanted to say was, did you take any history of decrease in the size of the swelling ever?
Yes.
No, ma'am.
So how is that important in your case? Any history of pain in the swelling, decrease in the size of the swelling ever? That it sometimes decreases and then increases in size again. One is that it will tell you about the benign pathology. Secondly, you will keep autoimmune pathologies in mind, autoimmune thyroiditis and So must take this history in all cases. That has it only been increasing or has it ever decreased in size also?
Okay.
Yeah, please go on. I think we can proceed to examination.
General examination. The patient examined after getting consent with adequate weight. Says conscious, oriented, afebrile, hydration adequate. Says pulse rate 80 per minute, measured in right radial artery, regular rhythm, good volume. Blood pressure is 120 by 80 mmHg, measured in right arm in supine position. She has no pallor, stress, cyanosis, clubbing, and pedal edema. She has no alopecia, no eye sense, and no tremors. Examination of neck. inspection. The patient is examined in a sitting position after getting consent and adequate exposure of neck and upper chest. A patient examined from front with the neck slightly extended. Single oval shaped swelling of approximate size 3 cross 2 centimeter over right side of anterior aspect of neck. Its vertical extent as 2 centimeter below thyroid notch to 3 centimeter above suprasternal notch. Horizontal extent 2 centimeter lateral to midline to 1 centimeter medial to the anterior border of right sternocleidomastoid. All borders are well defined with the lower border visible. The surface appears smooth. Skin or swelling appears normal. No dilated veins. The swelling moves with deglutition. Does not move the protrusion of tongue. No other visible swelling in neck. Structures and midline. Palpation. There's no localized warmth and dryness. A single oval shaped swelling of size 3 cross 2 centimeter present over right side of anterior aspect of neck. The vertical extent is 2 centimeter below thyroid notch to 3 centimeter above suprasternal notch. Horizontal extent 2 centimeter from midline to 1 centimeter medial to anterior border of right sternocleidomastoid. The swelling appears it has a smooth surface, well defined and lower border palpable. Plain is deep to deep cervical fascia. Firm in consistency. Skin or swelling is normal, no thrill. Bilateral carotid pulse palpable. Staircase in midline. Lymph node examination. There is no clinically palpable cervical lymph nodes. Oral cavity examination normal. Systemic examination. Cardiac system. S1, S2 present, no murmur. Respiratory system. Bilateral RNT present, no added zones. Per abdomen. Soft, no palpable mass organomegaly. CNS, no focal neurological deficit. Summary. Middle-aged woman with no risk factors present with complaints of swelling over front of neck for past 2 months. On examination, there is a single firm swelling of size 3 cross 6 centimeter in region of right lobe of thyroid, which moves up with the deglutition, firm in consistency with no palpable lymph nodes.
You have to commit and say no diagnosis so that we'll ask you that question. You have to tell the diagnosis now, not summary. Yeah, this is how it is. Yes, summary is correct. Yes, at the same time, please remember this is a examination. PG examination may differ from slightly the conduct, but after the COVID and all, it has become like what is that? Because of virtual thing. History wise one summary at the end of the summary. So in your answer sheet, whatever you write, case sheet.
Yes, sir.
Write all the finding, then give the diagnosis. Okay.
Yes, sir.
It is for the examiner to ask you. If they ask you summarize, quickly you tell. Okay, solitary nodule involving the right lobe, thyroid state.
Naveen, what do you understand by solitary thyroid nodule? You know, the diagnosis which you are giving is just, it's a physical finding, isn't it? It's not the diagnosis.
Yes.
So what is a solitary thyroid nodule?
Single lesion over the thyroid region.
Do you know what are the reasons for the solitary thyroid nodule?
Sorry,
what
sir.
are the various reasons for the solitary thyroid nodule? Is a clinically palpable solitary thyroid nodule is always a solitary nodule?
No, sir.
So what is the commonest cause for the solitary thyroid nodule?
Goiter is a colloid goiter.
Yes.
Follicular adenoma.
Yes. So what are the other?
Colloid cyst, sir.
Yes, it can be a multinodular goiter. Part of the colloid goiter it may be. It may be neoplastic, which may be benign, or it may be malignant, or it can be cyst may be there. or some
Okay.
inflammatory pathology may be there. So all are the differential diagnosis for the solitary, because solitary thyroid nodule, you are just telling that there is a nodule which you are able to clinically feel that, but that is not the diagnosis.
Okay.
You have to tell about that. What do you think in this patient? Do you think it is a part of the multinodular goiter or a colloid nodule? Or is it a neoplastic? Or is it a cyst? Or it's inflammatory?
Sir, she probably has a benign colloid cyst, sir.
What is the age of the patient?
40 years, sir.
Okay. So in this age, what is the commonest? Can it be neoplasm or not? And if it's a neoplasm, what type of the neoplasm do you think?
Follicular carcinoma, sir.
Okay. Do you have follicular adenoma also?
Yes, sir.
So once you say the neoplasm, you cannot say it's a carcinoma as such. But though the history is very short in this patient, only how many 2 months history?
Yes, yes, sir.
Yeah. So it's a very short history is there. Not what is the difference between a sudden increase of a thyroid swelling and rapid increase of thyroid swelling? What is the difference between these two words?
Sudden increase may be due to any hemorrhage or a recent trauma.
Yes.
Rapid increase may be due to any carcinomatous involvement.
Right. So, okay. Right. Now, you said that trachea is in the midline in this patient, is it? How did you check
Yes,
for
sir.
that? How
So we
did
have
you
to
check
keep
it for?
to extend the neck, and we have to keep 3 fingers.
So that is on palpation, isn't it?
Yes, sir.
Can you tell on inspection also that the trachea is shifted?
Yes, sir.
How? How can you tell on inspection that the trachea is shifted?
The prominence of the sternocleidomastoid.
Right. So prominent sternocleidomastoid, if it is there, the trachea shifted to that side. Okay. Any other way to tell about the trachea?
X-ray, sir. Radiological.
You can
X-ray, sir.
auscultate?
Radiologically.
No. Clinically, no. We are just on the clinical examination. You can
Okay.
auscultate, and
Yes,
see
sir.
if the trachea shifted or not. So you can tell the trachea on inspection, on palpation, as well as on the auscultation also. Right. Did you palpate the carotid pulsations here?
Yes, sir.
Which carotid do you feel?
Common carotid, sir.
Okay. Where did you?
Right common carotid arteries.
Where did you feel the common carotid?
At the level of C6 vertebra, sir. Cassagna's tubercle.
So where does it correspond? The C6 vertebra? Clinically, how will you know that? Where is that? Where you will put your fingers to palpate the carotids?
Upper lateral to the oblique line of thyroid, upper part of thyroid cartilage.
You know any muscle there, big muscle which is there? Which is the big muscle on the lateral side? Sternocleidomastoid, isn't it?
Yes, sir.
So where does it correspond? Where you will feel for the common carotid in relation to the sternocleidomastoid? Okay, usually in the middle third of the sternocleidomastoid. So you will not put your one finger there, but you will put 2 or 3 fingers in that groove, and then you can feel that.
Okay,
can you feel the internal carotid in the neck?
No, sir.
Where do you feel that internal carotid? If you have to feel it?
You have to keep finger in the tonsillar fossa, sir.
Okay, right. Did you auscultate your swelling?
Yes, sir.
Okay. Where did you auscultate?
over the superior pole, sir.
Okay. Why superior pole? Why not inferior pole?
Because in superior pole, the superior artery goes superficially, sir. In the inferior pole, the inferior thyroid artery goes beneath the thyroid lobe.
So do you get the inferior thyroid artery at the inferior pole?
No, sir. Upper 2/3 and lower 1/3 in the junction.
So on the inferior pole, you only, which vessel is there on the inferior pole? Which vessel is there at the inferior pole?
Inferior thyroid veins.
Yeah, only the veins are there. You know? Inferior thyroid, one or more veins may be there at the inferior, not the artery. You know? Artery comes on the site.
Okay.
Okay. So that is why you always auscultate at the superior pole there. Did you tell about the eye signs in your patient?
Yes, sir.
Okay. How do you look for the ophthalmos? Exophthalmos, how do you see for that?
Sorry, sir.
How do you see for the exophthalmos? What are the various ways to see for the exophthalmos?
Sir, we have to ask the patient to look downwards.
You ask the patient to look downwards, then you will see the exophthalmos. Now you can see from the front, you can see from the side, you can see from the back. There are three positions to see for the exophthalmos. So from the front, how do you say the patient has the exophthalmos? You will see the eye of the patient, and what you will see in the eye?
Sir, I will protrude out, sir. The both lids will upper eyelid will be retracted.
Can you see the upper limbus of the sclera normally?
No, sir.
So that is the most important thing, that you can see the limbus all around. So you just by seeing, you can tell the patient has exophthalmos. So if you can see the white sclera above the upper limbus, that is a feature of the just on inspection, you can tell that.
Okay.
Okay. All right. Did you check for the myopathy in your patient? The patient can have the myopathy. Did you check for that?
Yes, sir.
How do you check for that?
We checked for proximal muscle weakness, sir. I asked the patient to stand from squatting position.
Good. Okay. Did you check for the reflexes of the patient?
Reflexes. Sorry, sir.
No, tell what are the various things you see in the neurological examination of the thyroid patient?
Tremors, sir.
Yes.
Tremors. Excitability.
Excitability, okay.
Proximal muscle weakness.
Yes. Reflexes. You know reflexes? Okay. Dr. Shinoy, you can take over here.
Just not to Naveen. Naveen?
Yes, sir.
Yes. Just go to one slide back. That's all. Yeah. So, no local raise of temperature and tenderness, correct?
Yes, sir.
That's what you have written. So, what you could have probably written is, depends upon your place, palpation, first I would like to do from behind. I know it is taken for granted, but I think you have to mention this point. Okay. That's classical method, correct?
Yes.
On palpation, you have written single oval shape, all that thing you have written. Now, vertical extent, horizontal extent, smooth surface, round border. Lower border you have written. Better to add that word. Why it's important? Smooth surface, round border. Hello? Can you hear
Yes,
me?
sir.
Can you hear me? Hello?
Hello, sir.
Can you hear me?
Sorry, sir.
Can you hear me?
Yes,
Yes,
sir.
sir.
Smooth surface, round border. So that's what you should follow. See, what we are interested to know is a smooth surface, round border, so that we are not talking about irregular borders, so which can cause, say, malignancy, etc. Okay.
Yes, sir.
Smooth surface, round border, well defined, correct. Lower border is palpable. Now, next slide. I'm not sure whether you have written most with the deglutition to be confirmed here. Okay.
Okay.
Most with the deglutition. Okay.
Yes.
And just go back. No, don't jump. Plain, when they ask you any swelling which moves with the deglutition, your answer should be deep to pretracheal fascia. Okay.
Okay.
You don't have to write that statement that a plane is deep. You just commit yourself to say most with the deglutition. It's for the examiner to ask you, what does it mean? It means it is deep to the pretracheal fascia. Okay.
Okay.
You understood?
Yes, sir.
Because any structure which is deep to the pretracheal fascia, which moves with deglutition. Maybe some other time we can continue with that because of time we can say. So consistency, mobility, fixity, plane of the swelling, then comes the other things. Skin over the swelling. See, it is not as thyroid is a different. Skin will be normal unless you see a scar, ulceration, fungation, etc. Right?
Okay. Yes.
So you have to just keep it in mind, all these things here. Okay. And most importantly, I don't know whether you mentioned in your case before you commit solitary nodule, because again, you are also other lobe. You have to mention. Have you mentioned?
No, sir.
That's very important. Whatever you are not written is not done in the sheet. You understood?
Yes, sir.
So if you want to commit yourself in solitary nodule, you would have mentioned now. Rest of the no other part. See, once you know that it moves with the deglutition, here onwards you can commit that it is a lobe of the thyroid, means probably other side. If the mass opposite lobe means other lobe is not palpable. Rest of the gland is not palpable. What method you follow to check for the other lobe?
Sir, lice method.
So at least in your case particularly, it has got a significance. Because if other lobe is palpable, what is your diagnosis?
Multinodular
Answer.
sir.
So as of it is a dominant nodule, other lobe you checked, let us say. So your diagnosis tilts. You are diagnosed, even now it can turn out to be a dominant nodule of MNG, but if you have got other lobe palpable. So it's an important clinical finding. Okay?
Okay.
Yes. So no significant lymph nodes you have written, and systemic examination you have written all that thing, but I'm not sure whether skeletal system, scalp you have mentioned here. See, it's important to mention after the cervical lymph nodes, that's your papilla in mind. Skull, that should come, and you have written oral cavity. What's the reason for that here? Suddenly has come here. What do you have in mind?
Sir, to note any oral malignancy, sir.
once you have a swelling which is now moving with the deglutition and committed yourself that you could have given another answer. That's a different issue, not definitely oral malignancy. So you can just completion say it is different. No cervical, no significant lymph nodes. After that, skull and spine. That is a standard thing we tell. But however, skeletal spheres, you look for any bony swellings. Pulsatile has been already mentioned to you, right?
Yes, sir.
So then comes your written rest of the examination. It's normal. That's how we can proceed. Okay.
Yes.
I think because time constraint, yes, please, anybody can take. Diagnosis and proceed, I think. Yes. Yes.
So my provisional diagnosis is solitary nodule of thyroid involving the right side of the euthyroid status.
So now what will you do for this patient?
Go ahead.
How will you
Go ahead.
investigate?
Yes.
Is this diagnosis complete?
Solitary nodule thyroid.
Please add to it that with no features of either pressure symptoms or symptoms of infiltration. Symptoms and
Yes.
signs of infiltration.
Okay.
And also just writing that the swelling is deep to deep cervical fascia would be a wrong statement to make. Dr. Shenoy sir has already pointed out because deep cervical fascia has got 3 layers. And one of the layers is prevertebral fascia also. So you cannot just make a statement that it is deep to deep cervical fascia. What you probably wanted to say is that it is deep to investing layer of deep cervical fascia. Yeah, proceed to how will you manage this case?
First, I will do an ultrasound neck. Then I do an TFT, thyroid function test. Then I will do on FNAC. If there is no abnormality in the TFT.
You may classify your investigations that you may want to do investigations to evaluate the functional status of thyroid and the nature of swelling in thyroid, and if there are any other swellings other than this nodule in the neck. And then go ahead.
Okay.
Yeah, please continue. So why would you want an ultrasound neck?
Yes, madam. Also, hey, Naveen, just add you. See, go back. See, go back. Yeah.
It's in my hands, sir.
See, what this is your this one, no? Your ultrasound finding, correct?
Yes, sir.
Now, what about the comment on the other lobe? See, I want you to learn, not just looking at this report. Was there any comment? This is what exams ask you in the PG exam. Okay.
Okay.
You understood?
Yes, sir.
Clinical examination may tell right lobe, but see, ultrasound sonologist, obviously sonology arm is better than our arm to pick up. Okay.
Okay.
Bilateral lymph nodes. Where did you look for this? You have written 1B. What is it? B dash L. What is that? What is that other thing?
Bilateral, sir.
11. Oh, sorry. Bilateral 1B. What is that?
Sir,
because some things you
submandibular.
So is it important to your case?
Yes, sir. There is a lymph node metastasis. Now we have to, if there is any palpable lymph nodes, we have to think for any malignancies.
So 1B. That's why I asked you that question. Submandibular thyroid gland, does it drain there? See, these are the things you need to read when you're presenting. Okay.
Okay, sir.
I mean,
Yes, sir.
where does the thyroid drain? At least tell no something.
Sir, level 2 and level 3
Level?
nodes, sir. Level 2, level 3 nodes.
3, 4, 5, even 6, all that is anything but here and there 1B. So in other words, submandibular may be due to something else in the oral cavity. That's a different issue. So what you should mention is clearly the nodes. So that's what sonologists will expect you to tell this. Other than that, taller than wide, there are many things. I don't know what you written. That's okay. Cystic lesion, 7 mm noted. Sir, it is sir.
Yes. Naveen, what are the things you will like to know if they are not subcentric lymph nodes and if they are larger than that and they are in the levels of thyroid
Yes.
area? What are the things you will like to know of lymph nodes and what are the things you will like to know of lobes, which can lead us to the presumption of benign versus malignant pathology? You can say one by one, either lymph node first and then thyroid nodule, or thyroid nodule and then lymph node.
Sir, there's a lymph node in that level 2, level 3, level 4, level 5. You have to look for
Yes,
any
label. One is label. Then what are the morphological features you would like to know from ultrasound?
round hypoechoic.
What is the normal shape of lymph node? Now, Dr. Naveen, what is the normal shape of lymph node and how they are described by radiologists on ultrasound? They are vertically ovoid with preserved hilum. The architecture of the lymph node border is preserved. This is how it is mentioned, right? If they are globular or in shape, then it is presumed to be abnormal.
Okay, sir.
And the other way around is for thyroid nodule. If they are, what are the things you will like to know in thyroid? You have mentioned thyroid 3. So what are the features?
In thyroid 3, we have to suspect any probably benign nodules, sir.
Okay. Okay. The
No,
features
you have
favoring.
been, sorry,
Carry
you've
on,
been
carry
given,
on.
sorry, you've been given these findings 3.4 by 2.6, cystic lesion with thick internal septations and vascularity. What is your interpretation about this nodule?
It may be benign
We
cystic
assume
lesion.
that the nodule that you've palpated is this nodule that you're seeing on ultrasound.
Yes,
Now
sir.
give us your interpretation of the ultrasound finding of this nodule. It's clear it's a cystic swelling. The
Yes,
very
ma'am.
fact that it has septations means it's a complicated cyst. And if these septations are vascular, then why would you think in terms of a benign swelling only? You would keep a high index of suspicion of a malignant cyst.
Okay.
It looks like a complicated cyst.
Okay.
So how will you proceed now with these findings? You have this report of ultrasound neck. How will you proceed?
Then I will do a thyroid function test, ma'am. There is
Sorry, you will do?
thyroid function test, ma'am.
No, we assume that you've done them and the patient is clinically and biochemically euthyroid. Okay.
And proceed with the FNS, ma'am, fine needle aspiration cytology.
Yeah. So how will you, where exactly will you aspirate? It's a cystic swelling and you will do fine needle aspiration of a cystic swelling. Or you have another solid cystic swelling. What exactly do you want to do? Please tell us. So maybe a good answer may be that you would want to aspirate the cyst for fluid cytology and do an FNA from the solid area of the solid cystic swelling.
Okay.
Hello?
Yes,
Dr.
ma'am.
Naveen?
Okay. Yes, ma'am.
Are we on the same page? Do the
Yes,
other
ma'am.
examiners agree with this? Cytology of the fluid
Yes, ma'am.
and
Yes.
FNA from the solid area of the solid cystic swelling.
Yes, madam, definitely.
So what exactly do you want to see in the cytology of the fluid? And what exactly, how would you say that FNA from the solid cystic area is adequate or inadequate FNA? First, tell us what do you want to see in the cystic fluid? So it's a straightforward answer. You would look at it grossly. You would also send it for microscopic. On gross examination, you want to see whether it is hemorrhagic or non-hemorrhagic.
Okay. Yes, ma'am.
Sorry, then you send it for microscopic examination to look for any malignant or atypical cells. How do you say whether your FNAC is adequate or inadequate? So when you do a microscopic examination, you look at the number of acini that you've got and number of cells in each acini. And I stand corrected, it should be more than 4 to 6 in each.
Okay.
Right?
Yes,
What is the system by which you would evaluate the FNAC? Yeah, you've written, please speak out. Dr. Naveen, are we there?
Ma'am,
Yeah.
ultrasound guided.
Yes, so you've done it and it comes as Bethesda category 2. What do you interpret from this?
The FNAC report is Noller Poirier Gottel Bethesda category 2.
Yeah,
It
what
means,
is category 2?
Sorry, ma'am.
So this is benign. You may have benign features suspicious of malignancy, benign with atypia, and you may
Bethesda
have frankly
category.
malignant cells.
Bethesda category 2, it means we have to suspect a benign nodule, sir.
Yes.
We'll need to follow up the patient.
Okay, so our interpretation is that we are dealing with a benign cyst and a benign colloid nodule. Right?
Yes,
so
ma'am.
how will you manage this case?
We have to follow up the patient. If there is any sudden
Will
increase
you
in
decide
size.
for the patient?
Ma'am?
Will you decide everything for the patient?
No,
She
ma'am.
has a swelling in the neck. She's come to you for a reason. And you've told her that it's a benign swelling.
Yes, ma'am.
So you will give her options of management. Clinically, it didn't look very performing cosmetically. But if she's either very apprehensive or you find that she finds it cosmetically not good for her, you may consider surgery. Do you think this fits into the category of multinodular goiter?
No, ma'am.
Hmm?
No, ma'am.
Okay, and if it were a case of multinodular goiter, how would you explain that whether she should or she should not undergo a surgical management?
Hospitably, she will have some symptoms, pressure symptoms, dysphagia, breathlessness.
So would you want to
any
monitor
voice
a
change.
patient of multinodular goiter conservatively on medical management, or would you want to treat a multinodular goiter surgically?
We have to treat surgically, ma'am.
Yeah, so why would you want to treat it surgically?
For the risk of malignancy, ma'am.
Risk of malignancy, risk of hyperthyroidism, increase in the size of the swelling, right?
Yes, ma'am.
Yeah. So if she wants the nodule to be removed, what is the surgery that you will plan for her?
plan proceed with the right hemithyroidectomy.
Let's go back to your ultrasound report. The other nodule is also in the right lobe. Both the nodules are in the right lobe only.
Yes, ma'am.
Okay. Yeah. So, what is the difference between lobectomy, hemithyroidectomy?
In lobectomy, we will remove the particular lobe, and in hemithyroidectomy, we will remove the lobe along with the isthmus.
Along with the isthmus and the shave of opposite lobe also.
Okay.
Yeah. Any role of total thyroidectomy?
No, ma'am.
Why no? There are people who do total thyroidectomy in most of the cases. Why did you say very dogmatic no in this case?
She is in euthyroid state, and it looks like benign only, ma'am. We have to follow the specimen post-op.
So supposing you sent it for did a hemithyroidectomy and send it for histopathological examination, and the biopsy came as malignant cyst in the right lobe.
We have to proceed with the completion thyroidectomy.
Completion. So this is one reason why most of the people take up for total thyroidectomy in many cases. Going in for completion thyroidectomy may be a relatively difficult option later.
Yes.
Any other advantage of doing hemithyroidectomy, as you said, as compared to total thyroidectomy?
The other lobe produces thyroxine, ma'am.
Sorry, be loud and clear.
The other lobe produces, the other lobe is functioning normal and produce
No,
thyroid
that you
hormone.
can replace, no? Other than that, any other complication that is more likely to occur with a total thyroidectomy than with hemithyroidectomy?
There may be chance of injuring the laryngeal nerves, ma'am. Sorry, sir?
Yes, more chances of injury to recurrent laryngeal nerve and hypoparathyroidism also. Yeah. I think other examiners should take over. Would any other examiner want to take him in any other direction?
So I think we can slowly consider a day.
Yes, it is already 10:25.
Yeah. And reaching.
Kanagal sir, are you there? Kanagal sir?
Naveen,
yes, sir. I'm here, sir.
Yes, sir.
So the comment that I would want to make, Dr. Naveen, is that you seem to be in a hurry when you prepared your case. You were a bit casual in your presentation. You were also casual in taking the image of the patient because patient had her jewelry on and was casually dressed. And the nodule that you wanted to show us was not really very visible. Right? You seem to be a bright student and you should be able to demonstrate your knowledge and your clinical examination skills to the examiners more clearly. Right?
Okay.
Because you seem to know your answers, but you should be able to communicate your answers a bit more reflexly and in a more clear and loud manner. Very good. Well done.
Thank
You
you.
still need to the scope of improvement.
Thank you.
And one more suggestion, sir. They should be using the technology more. It took so long time for Naveen to do the setup of the presentation.
What? Sorry?
No. They should be using the.
Junior should be more technology friendly than
sir.
we people.
Yeah,
But sometimes
that's
it
what
is fault of net and technology also. Yes.
Yes, sir.
You're right, sir.
I'm also not used to this technology, sir. This is the first Zoom meeting.
For the first time, it has happened that both the candidates had some trouble, so we could start
Yes,
little
sir,
10 minutes later. Otherwise, one or the other candidate is well prepared.
I think
thank you all the senior faculty members, sir. Thank you for Kanagwell sir for giving me this opportunity. Thank you, sir. It was nice, sir, being with all you people.
Thank you, sir. Naveen, one thing I think every PD should know is that, everyone, Remember, the case will not come written on the forehead that I have got a thyroid swelling. See, in the exam, that's what happens. Number one. So you need to slowly build up your case, like a, how don't have to tell the true story only. Don't have to build up because the ultrasound report is there for thyroid size 3.2. All that's clarified. One. Second thing is you are telling here ultrasound report of your patient. But remember, in the exam, it will not be like that. If the clinical exam is there, people will ask you what will be the ultrasound findings. Then the later examiner may ask you, okay, if for somebody, I hope you understood.
Yes, sir.
You cannot go retro. Retro means you know the diagnosis that it is a case of multinodular goiter or choroid goiter or something, then trying to adjust. It is not like that in the examination. That's what I am trying to tell you. Okay. And do the complete clinical examination.
So be more logical in history taking and examination finding. Correlate whatever is fitting most appropriately. You should stick to that.
So, right.
Kanagwal sir, are you there? Kanagwal sir?
So we need to congratulate for the 5 lakhs, I think, viewers.
Yes.
Correct?
Yes. Views.
But he's not there.
I think he's there, but he's in a meeting. He told me to conduct. So thank you all faculties. Thank you, Dr. Naveen and Dr. Pooja. Please feel positive. There is always a scope of improvement for everybody. Don't feel any downgraded. It's a privilege to be presenting case here. Try to be better next time. All the best. Thank you, all faculties. Good night.
Good night.
Good night, sir.
Good night.